In this video, I'm discussing a case study of a gentleman with knee arthritis that we treated with his own bone marrow derived stem cells. Hello, this is Dr. Tambar, expert in regenerative medicine and rheumatology. Today, I'm discussing a case of an individual that we treated his knee arthritis with his own bone marrow stem cells. I'll discuss what was his condition, why did we select that treatment, what was our approach to treatment, what's involved in treatment, aftercare issues, as well as expectations for his results as well. So this is a 46-year-old man. He's a construction worker, does a fairly demanding job, having progressive knee pain. He's been seeing orthopedic, he's had x-rays done, has been told that he's got some osteoarthritis. He's reduced his activity level, he's stopped exercising, he's had steroid injections, taking anti-inflammatory medications, and he's still having pain. That's why he came to me. So upon my examination, he clearly had wear and tear arthritis in the knee. Because he's not responding to conservative measures, we ended up getting an MRI of his left knee, which showed that he had a moderate level of osteoarthritis in the medial joint. Medial joint is the part of the knee that's closest to the other knee. In most cases, someone who's got moderate level osteoarthritis of the knee, given his age, will likely probably do pretty well with just utilizing platelet-rich plasma. In his case, however, he has a little bit more than just that. On his MRI, what you see is that he's also got bone marrow edema or swelling within the bone above and below that medial joint, in the medial femoral condyle and the medial tibial plateau. That's very important. And the reason why is because the swelling of the bone is what can likely drive a lot of his pain. So the subchondral bone, that's the part that's swollen in his case, can not only drive more pain than even just the cartilage breakdown in his knee, but what's key here is that the cartilage itself and the joint itself typically does not have very good blood supply. What it does have, it receives blood flow and nutrients from that subchondral bone. And so if that bone is swollen and irritated, it can lead to progressive breakdown of the cartilage and more osteoarthritis. So while in a typical knee arthritis patient, we would be treating strictly the joint and the ligaments, and then treating any other soft tissue structures like the meniscus, tendons, maybe some small and trapped nerves if appropriate. In his case, besides all that, we also need to treat the bone because of the swelling in the bone. So when treating the bone, you can treat that with just his own platelets. There's some evidence that can work. There's also some better evidence that you can utilize an individual's bone marrow concentrated stem cells. So in his case, in order to get really the best result, and the best result for him is not only pain relief at rest, but it's also to get back to a very high level of physical activity at work. We decided in conjunction with a conversation with him to proceed with utilizing his own bone marrow concentrated stem cells. So how does treatment work? So to begin with, he has a bone marrow aspiration done from the back of his iliac crest. That's the back of the pelvic bone. It's important to take a sample from both sides, and the reason why is because if you take a sample from multiple spots, you get a better cell count and a better result than if you take it from one spot. So we take out roughly 4 ounces of his own bone marrow. We do this all under just local anesthetic. He does not need to be sedated for this. The reason why is because we utilize a lot of local anesthetic, and quite frankly, we do this on a lot of people. We know how to keep people comfortable without having to sedate them for this part of the process. So after we've taken out 4 ounces of his bone marrow, that then gets processed on site, same day, into a high concentration of his own bone marrow derived stem cells, as well as a high concentration of his own platelet-rich plasma. These 2 cells are then injected later on in the afternoon. So the keys to his injection in the afternoon are as follows. Anytime we do an injection, we have to do it under high-level image guidance. And the reason why is because when you're injecting cells, you have to be very precise in terms of where you're injecting. You can't just be close to the right spot. You have to be precise down to a sub-millimeter. So in his case, we first inject the medial joint. We do that firstly under ultrasound guidance, placing the needle into the joint. We then inject a tiny bit of contrast and then confirm under X-ray guidance that we're truly in the joint space. After we've done that, we then inject his high concentration bone marrow concentrated stem cells into the joint. We then redirect the needle and then under ultrasound guidance, injecting the medial collateral ligament, the main supporter of the medial joint. And we injected his own platelet-rich plasma there. Then lastly, under ultrasound and X-ray guidance, in particular X-ray guidance, we end up placing the needle into the bone above and below the medial joint, after which we then inject his own bone marrow concentrated stem cells as well as platelet-rich plasma into the bone itself. The actual placement of the needle into the bone is done without any significant pain, and the reason why is because we do that under a significant amount of local anesthetic. As we're injecting into the bone, there is some discomfort, and the reason why is because the bone itself is swollen and irritated. So for that part of the process, we'll do that either with some twilight or light sedation like you would receive for a dental procedure or a colonoscopy, or we'll give somebody a pain medication and perhaps a Valium just to keep it a little bit easier for them as well. Post-treatment, he'll have more inflammation for the first 2 to 3 days. If we're only injecting platelets and not injecting into the bone, then generally speaking, you don't need to be using crutches. It's just activity as tolerated. However, because we inject it into the bone and it's more irritated for the first few days, we recommend that he utilize a cane or crutches for the first 3 days, after which using an unloader knee brace to take pressure off the medial joint for the next 6 weeks. From a work standpoint, because he has a very heavy job, very physically active as a construction worker, we kept him off of work for 1 week. He then went to work light duty for another week and then is back to his normal duties after a full 2 weeks. He should be noticing improvement at the 3 to 4 week mark and then getting better for the next 6 to 12 months. My expectation is that he should do well. And by well, I mean not only pain relief during rest, but also pain relief and functional improvement so that he's able to get back to exercise and get back to and maintain a high level of work activity as well. So I hope that sums up and gives you a sense for why we're utilizing bone marrow concentrated stem cells in this case of knee osteoarthritis, how we'd approach someone with this kind of situation, which is not only knee osteoarthritis, but some bone swelling as well, how we would do the treatment, and what our expectations afterwards. Thank you for your time today. Give us a like, subscribe to the channel. Until we connect again, have a good day and live well. Bye-bye.